A 47-year-old man who works in an office presents with a 3-day history of sharp lower back pain. He had been helping to move various heavy boxes around the office before the back pain began. The pain radiates down the posterior aspect of his left thigh and calf. He has had no notable history of fever, trauma, or changes in his bowel or bladder functions during this time. Over-the-counter ibuprofen has provided little relief. On exam, he walks with a slight limp, but can do so without assistance. Ankle jerk reflex is absent on the left, and pinprick sensation is diminished on the sole of his left foot. Which of the following is most likely to also be seen in this patient? Choice A, difficulty standing up from a seated position. Choice B, difficulty rising from a full squat. Choice C, absent patellar reflex. Choice D, difficulty walking on the heels of his feet. Or choice E, difficulty walking on the toes of his feet. I'll give you 5 seconds, and then I'll start answering the question. So this is a really obvious vignette of a spinal radiculopathy. Specifically, obviously, this is a lumbar radiculopathy. Now, the etiologies are varied, and classically we would think of HIVD, a slip disc. But the etiology here isn't that important because the main goal is to test you on a neuro. And for those purposes, the most important thing you need to see is the final few lines here, which it tells you the ankle jerk reflex is absent on the left side, and the pinprick sensation is diminished on the sole of his left foot. And when we think about things in general terms, that sounds more like posterior leg compartment and the sole of the foot. And even if you're really bad at all the anatomy stuff, you would have a general sense that this would be like, okay, this is kind of more tibial region. But of course, you would also recognize that since the lesion includes a deficit on the sole of his foot, you would probably also logic out that what's involved here is probably more plantar flexion, and the answer choice that matches that most closely is choice E, difficulty walking on the toes of his feet. Now, for the purposes of this question, we're going to talk about lumbar radiculopathies, and we're going to focus on L4, L5, and S1 here. I'm going to try to make this really simple. This is not technically the correct way of thinking about them, but if you think about them this way, it helps simplify it, and it will get you a good chunk of these kinds of questions correct. When I think L4, I think femoral nerve. When I think L5, I think fibular nerve. And when I think S1, I think tibial nerve. Now, like I said, this is not an entirely correct way of thinking about it because there are tibial fibers in all of these actually. And there's just generally a lot of overlap between these spinal roots. But my point is that if you think about it that way, you can kind of logic out a lot of the symptoms you could see. So for example, in L4, because you're thinking mainly femoral nerve, you'd probably logic out that, okay, I'm going to have some problems with the quadriceps, knee extension. This is also where the absent patellar reflex would be found if there was a lesion. And as I mentioned, there would actually be some minor tibial symptoms as well, but mainly you'd be thinking femoral symptoms. So for L4, choices A, B, and C are all things that sound more like L4 lesions. Now, they technically could also be L2, L3, especially for choices A and B. But the point is that if you have a general sense, you would be able to recognize that, and you'd also be able to logic out the fact, just from a test-taking perspective, that A, B, and C can't all be right at the same time. That doesn't make a whole lot of sense. Only other thing I want to add here, which is only tangentially related, is that choice A, difficulty standing up from a seated position, that isn't only spinal radiculopathies. That could also describe things like Lambert-Eaton. So they might describe to you that the patient is wiggling around their chair a bit before they can stand up completely. That would sound like Lambert-Eaton, and then you would probably go chasing lung cancer or something. It could also potentially describe myasthenia gravis. So then in that case, you would probably be thinking like thymoma. But I don't want to get too distracted here. I was just throwing that in because that's a pretty high yield thing to know. So going back to what I was saying about separating L4, L5, and S1 into femoral, fibular, tibial, respectively, choice D, difficulty walking on the heels of his feet. Well, if you think about difficulty walking on your heels, that would be me flexing my foot dorsally. So that would be more of like a fibular nerve action, which is more related to an L5 lesion, which is what this is implying. So that's why choice D is the incorrect answer here, because like I said at the beginning, this answer is giving you a lot of hints that this is an S1 lesion because there is a lacking Achilles reflex and there is a loss in sensation on the sole of the foot, which all implies more tibial nerve distribution, which would be connected back to S1. Now, obviously, some of you are really, really good at the anatomy and you're going to nitpick me and you'll say like, well, this isn't exactly accurate. And I would probably agree with you on that. And we can spend all day sitting here talking about the finer points of the anatomy. But to me, it's a lot easier to think of this in general terms. And I feel like that typically can get you like 80% of the questions of this kind correct. Anyway, I hope this video was helpful. I'll see you in the next one.